Okay, so this is a sort of backup timeline and some other things. Matt, you can go on to the next slide of just treatment here. So I just wanted to review very quickly some of the timeline, the government response, kind of how we got to where we are very quickly in the last couple months, but really in the last couple weeks, and how locally people have responded. And it's great to hear already from Sheila what other programs are doing as well. So it's good to hear ideas and ways people are dealing with this. Let's keep on going. So just to review, in November 17th of last year, I don't know what's happened at the formatting there, sorry about that, but it's the first case in China, and then January 21st, first case here in the States. The 31st, not so long ago, but seems like forever, public health emergency was declared nationally, and then we got the first case in February, and on March 12th, Governor Evers declares a public health emergency here, and then just this week got the safer at home order to, which is still not sort of shelter at home, but just safer at home. So responses have been varied, but it's really brought us up to where we are today, and that's allowed for a lot of these variances that we've been hearing about. So continuing on, that in terms of the spread here, so this is just as of yesterday, and I looked at a couple of different websites and some differences, but on average, this is what I saw from yesterday. 707 cases in the state, 1 person is recovered, and 8 people have died. Dane County has 114. Milwaukee County has the most in the state, and we have had 1 death here in Dane County. You can see the numbers for the U.S. and worldwide. Something, I think I missed a couple of zeros somewhere, so or they got put in a different place. But in any case, the point of this is what I got from the DHS website was to keep calm and flatten the curve, which I thought was a good way to help keep in mind what we're trying to do here with our responses, and they seem to be varied as we've seen all of this roll out. So you can keep going. So in what happened to allow all of us to be able to make these variances and how we're providing care with the minimizing contact and social distancing were due to the Coronavirus Preparedness and Response Supplemental Appropriations Act, that's a mouthful, on March 6, 2020, which included a provision allowing the Secretary of DHS to waive certain Medicare telehealth payment requirements during this emergency, also known as the 1135 waiver. So this is just giving you a orientation because you're going to see some of these same words and phrases thrown around in many of the other things and documents that have been provided since, so it just gives you some background. The 1135 waiver really allowed us to do this. And since Medicare did that, and they said telehealth services provided, so when I made this presentation on Monday, this felt like breaking news, and now it's already feeling like old news because we have made some significant changes in the state as well. But it really opened up things. We had already switched last week to doing telephone visits, knowing that we probably were not going to be able to bill for them, but just wanted to keep as many people safe as possible. And looking a little bit more deeply into what Medicare described as qualified providers helped clarify a little bit. So we have some in-training staff, and we're not going to be able to recoup their time, but those are some ways to kind of consider if you have providers in these disciplines that you can get apparently billing essentially at this and payment the same as in-person visits, but only through the emergency. And so they said it could be for new or existing patients, and people don't have to go to a rural off-site clinic, but it can be right in their own homes. So it's pretty significant changes from what was happening before. And then on March 17th, the OCR waived potential penalties for HIPAA violations against healthcare providers, because all of this was like, well, hang on a second, if what about what we're suddenly able to do, is this legal? And so sort of like Darth Vader, they've made it legal, and now the rules have changed for us. So it's nice when the system can respond so quickly, including using widely available communication apps such as FaceTime or Skype, which my husband's an IT guy and big into security, and I asked him about longer term use, is this something that even makes sense from a security standpoint? And he said Skype is more well known for its security than FaceTime or some of the other platforms that are available. I don't know how Zoom holds up to a HIPAA review because they have a private closed source code. So those are some considerations that I can't answer, but those are things that we can think about, but we don't need to think about because the government says they're not going to enforce any of that during this time. So it could lead to sort of a Wild West phenomenon, but I think people are trying to be as careful and in good faith here, I think is the best way to think about what we're trying to do to get people through this emergency. Next slide, please. And so how does this relate to 42 CFR Part 2? So they said that it does not apply to the, even with this new emergency, to the extent that unless you decide as a medical provider that a medical emergency exists. And so SAMHSA has really said that allowed providers to make their own determinations about whether we would define it as a medical emergency. And I think, based on what I'm hearing from other providers in the city as well and statewide now, that it's pretty easy to make the connection that if we do not provide the medications for people because they're not able to come to our appointments very quickly, they get into what is a real medical emergency. So I didn't have to think too hard about this, but in case somebody gets hung up about that, I think that's the way that I would explain that if I needed to. Hopefully I'm not going to need to. Moving along. So what we have done here, there's been a pretty significant systemic response, canceling elective surgeries, modify standard procedures, really significantly limiting or eliminating visitors except by virtual visits, and clinics, as Sheila said, deciding really what's essential and what can be done as telehealth. We've heard about the OTPs, and then treatment centers now in Dane County are limiting admissions because of the single bed issue. Inpatient psych unit is also limiting admissions so that they can have people in single beds. Walk-in clinics are closed here at our clinic and the Treatment Readiness Center at Tellurian. So it's really going to put the squeeze on already a vulnerable population and people that are waiting. So I think that's it's important to be aware of that and also not get weighed down by it and not add to our own sense of moral injury through this, because we know what we would like to offer, but we're not able to right now. So just trying to do the best we can to help people through this, knowing that, as Randy said, a lot of our folks deal with stress by using, and this just puts them at even greater risk. Okay. Continuing on, I think what we are doing and how do we provide the office-based care? We've already talked about this, so I don't want to duplicate it, but the interesting thing is that with the telehealth, they've said that it can occur across state lines as a way to meet some of this need. And already the implications for billing and charging and stuff have changed for Medicaid in the state within the last week. So the telehealth type, if somebody wants to note it, is 940693 for a telehealth type charge entry, and then it's just for your level of service by time. So that's one way that literally I got that information yesterday, so I started implementing that as well. It's changing very quickly. So it's taken a good amount of sort of learning how to surf the wave and not try to control the wave through the last couple of weeks, but I think that's the best way to do that. Continuing on. So some suggestions here, as we've just talked about, who we've just looked at our next 2-week schedule to see who's stable enough for televisit. And some places are just saying all of them will be televisit. So kind of talking with what your clinic and your patient population is comfortable and appropriate for. One of the considerations that I do in my verbal consent is just making sure that when I'm talking to the person that they're in a private place and that they're not using speakerphone. So just some little subtleties that can help it feel better to do these televisits that are being done somewhat impromptu, and then continue prescribing the amount you feel is adequate, but as much as you feel is appropriate. And these in-home inductions, we've been doing for a while anyway, but intake can hopefully be done in person, as Sheila said, sort of minimizing the amount of time you actually need to do face-to-face, but recognizing that we do need to get things like the urine drug screen and looking for track marks and things like that. That's essential for our work. So I think it should not be something that we are overly cavalier about in this time as well, doing your PPEs and everything that you can. But always erring on the side of keeping patients alive, knowing that, yep, there are people who are out far away from pharmacies and so on. That's going to make it harder for them to get to, and trying to minimize as much time out of the house right now. So here's some conclusions. Situation is changing rapidly. It's been a bit slower to catch up, but I think we're really kind of getting the groove of how to keep up a little bit anyway on the treatment end, and this emergency has allowed relaxation of some rules and practice patterns. But I loved the idea of getting legal counsel from your system to make sure that what you're doing is okay, which is actually a little funny because our legal counsel is completely swamped with everything going on right now, so we're not getting immediate responses, and it's pretty much relying on the good faith part of our practices and hoping that what we're doing is indeed not going to be under too much scrutiny afterwards. But what it also brings up for me and for our system is this is working really well for many of our patients who have a hard time leaving the home and are having time getting, for instance, transportation or other issues to come to the clinic. Our no-show rate this week for my patients went from 50% to 1 patient out of the entire week that I was unable to contact because I was doing it by phone. So it really does change a lot and makes me wonder, would it be possible in some way to continue some parts of what we've allowed variances for during this time?